Welcome to another episode from the Veterinary Research Channel. Today, we delve into the fascinating world of veterinary diagnostics, specifically exploring a non-invasive technique that is proving invaluable in assessing respiratory distress in our canine and feline companions, lung ultrasound. Recent research has focused on the development and validation of scoring systems to quantify and monitor lung aeration loss using this imaging modality. And we will be discussing a significant study that investigated the reliability of a new lung ultrasound scoring system in dogs and cats. The study, conducted by Stefano Orrico and colleagues, highlights the growing importance of lung ultrasound as a rapid and non-invasive tool for examining patients experiencing respiratory distress. Traditionally, qualitative lung ultrasound has involved a subjective characterization of the lung based on the identification of artifacts, analysis of the pleura, and visualization of other abnormalities like pleural effusion or consolidations. This qualitative approach helps in determining the underlying cause of acute respiratory distress. However, the researchers point out that a quantitative approach can be particularly helpful in monitoring patients during treatment. In human medicine, several scoring systems have been developed to objectively measure the extent of aeration loss. The study mentions that various patterns can be recognized during lung ultrasound. A normal lung, described as an A profile, is characterized by horizontal artifacts known as lines, which should be associated with lung sliding, indicating normal movement of the pleural surfaces. In contrast, AB profile, often associated with interstitial syndrome, is defined by the presence of at least 3 vertical artifacts called B lines in a single quadrant, suggesting a decrease in lung aeration depending on the extent to which these artifacts affect the pleural surface. Other patterns include an irregular pleural line, which is a hypoechoic band with an uneven boundary and can indicate mild peripheral loss of lung aeration. A tissue-like pattern, also known as alveolar syndrome, signifies a complete loss of aeration in the affected area due to consolidation or atelectasis. Finally, pleural effusion is the collection of fluid in the pleural space, which can have various appearances on ultrasound. In small animal veterinary medicine, several B-line scoring systems have been previously developed, sometimes incorporating the description of tissue-like patterns. These scoring systems have been used to assess the severity of specific diseases, and research has shown that lung ultrasound can have higher sensitivity and agreement compared to chest radiography, even surpassing computed tomography in some aspects. These earlier scoring systems often involve counting B-lines and ranking them on an ordinal scale. Tissue-like patterns were typically assigned the highest score, regardless of their size. However, a more recent study in human medicine introduced a lung ultrasound score that calculates the percentage of the entire pleural surface occupied by the main identified pattern. The primary goal of this veterinary study was to evaluate the reliability of this new lung ultrasound score across raters with different levels of experience in veterinary lung ultrasound. The secondary objective was to assess the level of agreement among these raters in accurately classifying different lung ultrasound patterns. The researchers hypothesized that the new lung ultrasound scoring system would demonstrate good reliability and agreement, even among raters with varying experience levels. To achieve these objectives, the researchers conducted a retrospective reliability study, reviewing 40 lung ultrasound examinations of dogs and cats from a digital database. These examinations were performed by a single, highly experienced operator following a standardized protocol, where each hemithorax was divided into 4 quadrants. Within each quadrant, a scene loop was recorded, scanning each intercostal space in a zigzag pattern. The videos were anonymized and reviewed by 4 raters with different levels of experience: high experience, 2 medium experience, and 1 low experience, defined by the number of previous ultrasound examinations performed. The less and moderately experienced raters received a 3-hour training session from the highly experienced rater, focusing on pattern definitions and the lung ultrasound score assignment method. The lung ultrasound score was assigned based on the percentage extension of artifacts on the pleural surface in each of the 8 quadrants, 4 on each side. Each quadrant received a score ranging from 0 to 3. A score of 0 indicated an A profile with horizontal artifacts or a maximum of 2 vertical artifacts. A score of 1 was assigned if vertical artifacts or patterns like pleural irregularity or slight subpleural loss of aeration involved 50% or less of the visualized pleural line. A score of 2 indicated vertical artifacts or subpleural loss of aeration or pleural effusion associated with loss of aeration involving more than 50% of the visualized pleural line. Finally, a score of 3 was given if a translobar tissue like pattern or pleural effusion occupied the entire visualized pleura without any aerated lung being visible. The total lung ultrasound score was determined by adding the scores from all 8 quadrants, resulting in a range from 0 to 24. The raters independently reviewed all the anonymized videos and assigned scores to each quadrant and a total score for each case. They repeated this process after 3 months to assess intra-rater reliability. 6 months after the second rating, 40 individual videos were randomly selected for a further evaluation where the same 4 raters identified the prevalent pattern and described all identified patterns, noting their presence or absence. They also indicated the predominant or main pattern in each video. Now, let's move on to the results of this comprehensive study. The researchers found excellent reliability in both the calculation of the lung ultrasound score and the identification of different patterns among raters with varying levels of experience. The intra-rater reliability, which assesses the consistency of a single rater's scores over time, was also found to be excellent, with intra-class correlation coefficients greater than 0.90 for all 4 raters. This indicates that each rater was highly consistent in their scoring when they reviewed the same examinations again after a period of 3 months. Similarly, the inter-rater reliability, which measures the agreement between different raters, was also excellent, with an intra-class correlation coefficient of 0.980 among all observers. When comparing the scores of the medium and low experience raters to the high experience rater, the intra-class correlation coefficients remain high, ranging from 0.955 to 0.986. These findings demonstrate a strong agreement in the lung ultrasound scores assigned by raters with different levels of experience. Further analysis on subgroups of only dog or only cat cases also showed very high intra and inter-rater reliability, with intra-class correlation coefficients greater than 0.90 in all analyses. The study also used bland Altman analysis to explore the agreement between the high experience rater and the less experienced raters. This analysis showed a very low discrepancy, considered clinically acceptable, between the high experience rater and the medium experience raters. While there was a statistically significant fixed bias between the high experience rater and the low experience rater, the magnitude of this bias was still considered relatively small. Furthermore, Spearman's rank correlation showed a very strong positive correlation between the lung ultrasound scores of the high experience rater and all other raters. Regarding pattern recognition, the agreement between the high experience rater and the less experienced raters in identifying the main pattern was strong, with Cohen's kappa values all above 0.8. The agreement among all 4 raters in identifying the main pattern, as measured by Fleisch kappa, was also strong, with an overall kappa value of 0.855. Specifically, the researchers found almost perfect agreement among raters in identifying pleural effusion and translobar tissue like pattern, with kappa values of 1. There was strong agreement for the identification of A lines and B lines. Moderate agreement was observed for subpleural loss of aeration, and weak agreement was found for irregularities of the pleural line. The study also explored the consistency between raters in identifying all patterns, both main and secondary. Using Cochrane's Q-test, the only statistically significant difference found was in the detection of pleural effusion among all raters. However, when the low experience rater was excluded from this analysis, this difference was no longer significant. Now, let's move on to the discussion of these important findings. The researchers emphasized that their results indicate excellent reliability for the lung ultrasound score and pattern identification among raters with different levels of experience in lung ultrasound. This strong reproducibility suggests that the lung ultrasound score is an easily applicable tool for quantifying loss of lung aeration in dogs and cats in emergency and intensive care settings. The authors highlight the clinical importance of this reliability, particularly in scenarios where patients need to be monitored over time by different operators, such as a dog with cardiogenic pulmonary edema undergoing treatment. The data supports that even between different raters, the scores are repeatable, which is crucial in a real-world clinical environment. The bland Altman analysis, showing a low discrepancy between the high experience rater and less experienced raters, further supports the practical applicability of the lung ultrasound score. The very strong correlation observed between the lung ultrasound scores of all raters compared to the highly experienced rater reinforces the consistency of the scoring system. The strong agreement in identifying the main lung ultrasound patterns with almost perfect agreement for pleural effusion and translobar tissue-like pattern and strong agreement for lines of B-lines, is also a significant finding. The researchers suggest that the lower agreement in distinguishing between a normal pattern, a profile, and interstitial syndrome, B profile, might be due to the challenge of differentiating between cases with less than or more than 50% pleural line involvement with B lines. The identification of an irregular pleural line proved to be the most challenging, potentially due to difficulties in distinguishing it from small areas of subpleural loss of aeration. However, the authors argue that the clinical impact of such differentiation errors on the overall lung ultrasound score is likely minimal. While there was excellent agreement in identifying pleural effusion as a main pattern, a significant difference was observed in identifying minimal effusions as a secondary pattern when all raters were compared. However, the researchers note that these small pleural effusions were not considered clinically relevant. The study contrasts the current lung ultrasound scoring system with previously described systems in veterinary medicine, which often focus solely on counting B lines without analyzing the entire thoracic surface or considering other ultrasonographic signs like consolidations. The researchers highlight that their adopted scoring system, which is based on the percentage of pleural line involvement, offers advantages in quantifying aeration loss without overestimating it. It can be applied to alveolar syndrome with a tissue-like pattern, unlike B-line counting methods. They also point to human studies that have shown a stronger correlation between the percentage of pleural surface covered by B-lines and extravascular lung water compared to simply counting B-lines. The division of the thorax into quadrants allows for a comprehensive assessment of the entire lung lobe, and the scoring system enables rapid evaluation without the need to count individual artifacts. The authors emphasize the importance of standardized training for the lung ultrasound score, particularly in defining the thresholds between different scores to minimize discrepancies. They note that the distinction between scores of 1 and 2 depends on whether vertical artifacts or subpleural loss of aeration affect more or less than 50% of the pleural line, not on the presence of coalescent B lines. Misclassification of confined coalescent B lines or small subpleural loss of aeration as higher scores could lead to an overestimation of the overall score and decreased lung aeration. The pleural line is identified as a crucial element in lung ultrasound scoring, with recent suggestions in the literature to integrate pleural line artifacts further into the scoring system. The lung ultrasound score evaluated in this study offers a rapid method for quantifying lung aeration loss and can be applied to various lung and pleural space pathologies. A score of 3 is assigned in cases of complete loss of aeration in an entire quadrant, regardless of whether it is due to pleural effusion or a translobar tissue-like pattern. Scores of 1 or 2 are assigned based on whether the signs affect less than or more than 50% of the pleural surface. The researchers also briefly discussed the choice of ultrasound probe, noting that while some studies have compared different probes, their center has consistently used a linear probe for lung ultrasound. They believe that the linear probe allows for better exploration of the pleural surface, prevents pleural blurring and false thickening, and avoids altering the shape of the pleural line, which is crucial for the scoring system. They also highlight the importance of probe positioning, with a transversal scan parallel to the ribs, allowing for better pleural surface exploration compared to a longitudinal scan. Standardized procedures during examinations are essential for consistent pattern recognition and reliable lung ultrasound scores. The study used a 4-quadrant scheme for scoring, different from the 6-area system used in humans, due to the anatomical differences between humans and dogs or cats. The researchers found that subdividing the thorax into too many small areas in veterinary patients, especially smaller animals, could lead to scanning the same area twice with a linear probe, potentially altering the final lung ultrasound score. The authors acknowledge some limitations of their study. The use of archived videos from a single expert operator meant they could not assess inter-rater variability associated with image acquisition and scan performance. They also discussed the inclusion of pleural effusion in the scoring system, which, while clinically relevant due to its potential to cause atelectasis, could create some confusion between intra- and extra-lung diseases and limit the use of the lung ultrasound score as a purely diagnostic tool. They emphasize that diagnosis should be based on pattern recognition, with the lung ultrasound score primarily intended for evaluating the severity of aeration loss and for monitoring purposes. The clinical context and chronicity of the disease should also be considered. The exclusion of some poorly recorded examinations was another limitation, potentially underestimating inter-rater reliability in challenging clinical situations. Finally, the raters were not provided with clinical information and had no time limitations for reviewing videos, which differs from emergency scenarios. The authors suggest that future research could include a test of agreement with respiratory function tests and advanced diagnostic imaging to further validate the lung ultrasound score. In conclusion, this study provides compelling evidence for the excellent intra- and inter-rater reliability of the lung ultrasound score and pattern identification in dogs and cats. The findings offer a strong foundation for the wider adoption of this lung ultrasound scoring system in veterinary emergency medicine and intensive care for both diagnosis and, importantly, for monitoring the progression and response to treatment of respiratory diseases. Thank you for listening to the Veterinary Research Channel. A link for the referenced paper is in the video description. Remember to test your knowledge by answering the questions in the description, and as always, keep those minds inspired, hearts light, and tails wagging.